this, we will post it on the intranet for those that couldn't get signed on, wasn't convenient for their schedules, just to make it available to others. I'd like to welcome Perry Junjulas. I'm Father Tony Green. I'm part of the Diversity, Equity, Health Equity, and Inclusion Committee here at Ellis. So we're happy to have Perry, who's the Executive Director of the Albany Damien Center, an HIV peer-led agency in Albany, New York, founded in 1988 that provides HIV prevention and care services in a comfortable, supportive environment for people living with and affected by HIV and AIDS. Since his AIDS diagnosis in 1995, Perry has worked to ensure a better quality of life for those infected and affected by HIV and AIDS by providing advocacy, leadership, and programming that is preventing new HIV infections while helping individuals and families access the treatment and care they deserve. He has served as the Damien Center's director since 1999. Perry is a graduate of Siena College and a 2010 graduate of the UCLA Johnson & Johnson Healthcare Executive Program. He completed the MBA program at the College of St. Rose in 2014. Perry served on the governor's Ending the Epidemic Task Force and is currently a member of the New York State AIDS Advisory Council, board co-chair of the Albany Coalition on Homelessness, board member of the Pine Hills Neighborhood Association, and member of the AIDS Advisory Council's Ending the Epidemic Subcommittee. And just full disclosure, Perry is also my husband. We were just talking about it last night. 6 years, been together for 16. Right, so welcome, Perry.
Thanks, Tony. And yes, that's probably my most important role as husband. And I think it's 9 years, Tone.
Yeah, I got it wrong.
No, I'm usually the one that can't remember the time, but I want to thank everyone, and especially thank the Diversity, Health Equity, and Inclusion Committee of Ellis Medicine for inviting me here today to talk a little bit about, well, about HIV and AIDS. And you're also going to hear a little bit of my story. So I'm going to share my screen, and hopefully we'll have some time in the end if you have any questions you'd like to ask. So can everyone see the presentation and hear me okay? Great, I'm seeing Tony nod his head, so.
Yes.
Great, thank you. So we just passed a milestone back on June 5th. It was 40 years ago that there was a relatively obscure article in the CDC's MMWR publication that talked about 5 men who had a mysterious illness that was related to pneumonia. And this was the first reported published case of HIV in the nation at the time. Now, if we look at some of the numbers, I just threw some random facts together. We've got 700,000 people have died of HIV and AIDS in the United States since in the last 40 years. We have 38 million people worldwide living with HIV today. 1.2 million people in the US have HIV. Of considerable note, about 13% of them don't know it, and they need to have an HIV test so they can be identified and get into treatment. In New York State, we have 117,000 persons living with HIV. The percent of people who are HIV virally suppressed in the US is 57%. I'm going to talk about a little bit about HIV viral suppression. That number is fair. It's okay. We definitely can do more to get that number up higher. Tony and I like to watch Naked and Afraid. And one of the things that always amazes me about the show is that it's really more about the mental abilities of each person to get through each challenge. And I just love this quote from Fannie Flagg: as being a successful person is not necessarily defined by what you have achieved, by what you have overcome. So I'm going to talk a little bit about me, because my story kind of delves into HIV and the Damien Center. So I was diagnosed with AIDS in 1995 at the age of 29. I had a very difficult seroconversion. I had lost a lot of weight, numerous hospitalizations and surgeries. At the time, I chose not to go on disability, even though everyone told me to. But I went to the Damien Center for help. And so my new way of thinking at age 29, now remember there was only one medication, it was AZT at the time, and it really was not very good. My new way of thinking was short-term only. The doctors, the case managers, everyone reinforced that I probably wouldn't survive, so I had to get my affairs in order. So we had a lot of increased risk taking, some very poor health habits. I remember them saying, eat a lot of chocolate cake because you have to put on weight. Just keep eating chocolate cake. So I started going to the Damien Center in 96, where we found out who died that week, talked about who was going to die next, and actively worried that I would be next. It was amazing back in those days. It was a room, two rooms on Clinton Avenue in 1988. It was started by as a ministry of the Capital District Episcopal churches and their friends to meet the crisis of the AIDS epidemic. And it was non-medical in nature. It was really just a super secret place for people to gather to try and figure out how we were going to deal with dying from AIDS. It was one of the first drop-in centers for people living with HIV and AIDS in the nation, for what we have been able to research. What I found when I was there was just an incredible camaraderie. Here were people from all different backgrounds. We had one thing in common. We were diagnosed with a disease for which there was no cure and for which we were watching everyone die at the time. And so we bonded. And that was also the place where we got our information. Back in 1996, when I went, there still was not the computers or the internet where you got your information. It was really from the people that were there. I remember someone pulling me aside and saying, I have to tell you about this super secret program called ADAP, the AIDS Drug Assistance Program. I was like, oh, I gotta find out more about that. It's how we got our information back in the day. Now, slowly over time, the medicines came out. They weren't great, but they were keeping us alive. We called it the Lazarus effect. And so I feel very fortunate to have been one of those persons that was on just about every AIDS med out there. And all these years later, and I'm doing pretty well, which is not the case for a lot of people throughout that time. So yeah, we were at Grace and Holy Innocents Church. And it was really focused on the end of life back then. Over time, and this is our new center, we are helping people to live with HIV. Still not, it is still very difficult for a lot of people, and we focus on the social determinants of health to reduce barriers to care. So the Damien Center services, just in brief, we have a drop-in living room, which I'm very excited to be reopening on the 21st of June, finally. We had converted all of our services to takeout, delivery, essentially in the parking lot. Now we're going to be able to let people back in. We're still going to be using masks and practicing safety precautions, but we're going to be able to actually have people come back in the building. We have housing on site for 20 people, plus we have 15 scattered site apartments. We have a meal program serving homemade breakfasts, lunches, and dinners, combined with nutrition, health, education. We have behavioral health, a pharmacy on site, a pause program. You can see Sammy there. We help people with their pets when they're ill, to take care of their pets, and also provide supplementary veterinarian care and pet food. We have an employment program, which is helping people to get back to work once they have achieved viral suppression. Our Empower program is serving our LGB and our TGNB community, regardless of HIV status. We recently took over the Capital Region Names Project, which uses the memorial quilt as an HIV prevention tool. We also are much looking forward to getting back to offering massage, Reiki, and spiritual care in the building, and combined with a lot of social and recreational activities. Now, these are all served in a trauma-informed, low threshold, and loving environment. So a little bit about HIV. So new HIV infections, they occur when an HIV infectious person and an HIV negative person engage in risk behavior. Kind of common sense, right? Well, virtually there are no new infections if the HIV positive person is what we call HIV virally suppressed or undetectable, or if the HIV negative person is taking PrEP, which is the once a day blue pill, not the one you're thinking of, the other blue pill, which is PrEP. It has been shown to be effective in preventing HIV. We'll note it does not protect against STIs or hepatitis C, but there are cures for those. Short of that, there are no new HIV infections if the individual uses condoms consistently and correctly and does not share injection equipment. So what is undetectable versus untransmittable? HIV viral suppression is the key indicator today of a person with HIV's health status. It also, since the science came out in 2016, ensures that they physically cannot transmit HIV to others. This is, to me, one of the most groundbreaking things to happen in HIV prevention, but also in our unending quest to end HIV stigma, is that now persons with HIV who are on medications can say, I cannot infect you. I cannot physically infect you. It is scientifically impossible. So HIV viral suppression, or an undetectable viral load, it just means that there's a very, very low amount of HIV virus that is present in the bloodstream. And this HIV viral suppression is due to taking the medications that are available today. So why are there 40,000 new HIV infections in the United States each year? And I want to say that not only are there new infections, but there's also persons who come to our organizations not having ever known that they were HIV infected, and they have already advanced to full-blown AIDS. Well, it is the contextual factors, the social determinants of health, because new HIV infections, they do not happen in isolation, but rather they come tied to numerous contextual factors: poor healthcare, poverty, mental health problems, and geographic disadvantage. So for poor healthcare, we see that there is a lack of access to medications, condoms, or clean syringes in many parts of the country. Thankfully, in New York, we are well ahead of the curve on this, but there still are areas that are having trouble accessing. There's a lack of health support. Peer navigators, we know, are very essential to helping people with medication adherence and also insurance support. There's often no easy access to HIV or STI screening and treatment. And by easy access, a lot of times we're talking about things that are trauma-free for persons who are going in to get a test that is accessible on their terms. There also is a delay from testing to linkage to care. And this is probably one of the largest problems that we have, is that we'll have someone that gets an HIV test, and then there is a long delay before we're actually able to get them into care, where HIV is really doing a number on their immune system. And finally, one of the things that I've really been working very hard to try and get through the New York State legislature, along with other advocates, is we have a lack of age-appropriate sexual health education in New York State. And that is definitely an indicator of poor health care when we are not educating our youth as to how to stay healthy and protect themselves. Now, poverty is the second factor. A lack of housing, food insecurity, unemployment, underemployment, survival sex work, and inequality, which includes a whole host of items there. Racism, incarceration, stigma, it's highlighted in red, disempowerment, bullying, domestic violence, unfair drug laws, all contribute to HIV infections. This is an actual spot in Albany, New York, back in 2016, behind a dumpster in a church parking lot, where one of our chronically homeless persons who was living with HIV lived prior to moving into the Damien Center. Now, I knew this is where they were. At least I knew they were sort of secluded, they were safe, and I could keep an eye on them, make sure that they were coming in for food, We even would run medications out to them to see if that would be something that they could do. But this, again, is not a way that someone can manage their HIV infection, nor is it something in 2021 in the capital region we should accept as okay. Contextual factor number 3 is mental health. That we include in that stigma, trauma, depression, substance abuse disorder, impulsivity, fatalism, religious guilt, and cognitive problems all create huge barriers to a person getting into HIV care. And then finally, geographic disadvantage. We do find that if you're engaging in risk behavior in an area with a high prevalence of HIV, you're going to be more likely to contract HIV. Similarly, if you live far away, and far away could be that you just don't have transportation to be able to get across town, to be able to get to your medical appointments or supportive services, that distance will create barriers for you. So when we talk about these contextual factors, we have to bring up key populations, which is our men who have sex with men, especially Black, Hispanic, Latino, and Native American men who have sex with men, all persons of trans experience, women of color, injection drug users, and serodiscordant couples. Now, these demographics of themselves don't place people at a higher risk for HIV infections, but rather when you combine all those contextual factors that we just talked about in which HIV occurs, these key populations, it amplifies their risk for contracting HIV. And certainly in these categories, we are seeing disproportionate numbers of persons both becoming HIV infected, but also not having good health outcomes with HIV. The contextual factors, though, are our opportunities to intervene. So back in 2014, we instituted a plan called Ending the Epidemic. It focused on 3 pillars. Number 1, to get every person who is at risk tested for HIV and get them into care. Number 2, for every person who is living with HIV, ensure that they are getting not just treatment, but early treatment, that they're getting on medications right away, and that they're staying on those medications to achieve that viral suppression. And the third leg is to get every person at risk for HIV who is not HIV positive onto PrEP, again, the once-a-day blue pill, that is preventing new HIV infections. We have had some tremendous success since 2014 by employing this strategy, but we also have a long way to go to be able to help the number of people who are still continuing to suffer from the contextual factors related to HIV, who are just not able to be able to take their medications or to be able to see the doctor as they need to. Why end the epidemic? Well, here's a picture of our crazy family, and we have 6 grandkids pictured here. And I think, one of my dreams is to have a world without HIV, that each one of them will maybe read in a book about what the HIV epidemic was at one point, but that it's not a factor in their lives. And so that is why we want to end the epidemic. There's my contact information, and wanted to see if there were any questions.
Thanks, Barry. Everybody out there can unmute and ask questions, or you can type it in the chat and I could ask the question. Just a quick follow-up for me, Perry. You and I were talking about, the possibility of making an HIV test part of routine medical care, the same as you would your glucose or your cholesterol, those sort of things. Where does that stand within the medical community and legislators?
Well, I can't speak to the medical community. I believe that the medical community, would be, of course, for identifying any type of disease early with that. But certainly a lot of things we have seen that go through the legislature do affect some positive change. For example, I'll give an example, and I don't remember the year, but they mandated that all mothers and newborns be tested for HIV. So it is amazing in New York State. We've gone close to 2 years with only one baby being born with HIV. There was a time when that number was through the roof, that there were many children being born with HIV. Now, again, this is just New York State because New York State law mandates that mothers and a newborn child be tested, and then they, of course, receive treatment after that. We're a little split on this, which is unfortunate. I am of the opinion that it should be a part of routine care. I believe we've heard from a number of people that just figured they were getting an HIV test when they got their blood drawn. And so we are working, we do have a bill that is asking for it to become a part of routine care. But we still have some activists that are very worried, and rightfully so. We have a very long 40-year history of discrimination, of horrible things happening to persons because someone has found out about their HIV diagnosis. And so their main concern is that we still need to keep some of these barriers, if you would, up to be able to protect persons with HIV. Again, it's my feeling that it's better to know than not to know. We are still seeing persons who are end-stage AIDS when they're discovering that they're HIV positive, and by then it's often too late because there's too much going on. And it just shouldn't be. I mean, to quote Dimitri Daskalakis, who was the head of the New York City Department of Health in the HIV division, we have the tools in our hands to prevent infection and to keep people living healthy with HIV. Our barriers now to achieving this vision is no longer science. It is though systemic racism, sexism, homophobia, and transphobia that is preventing us. And I think this is very powerful. Science used to be, back when I was diagnosed in '95, science was the big part of why so many people were dying. We didn't have the meds yet. We didn't have the treatment possibilities. We have those now. We know how to end this epidemic. We just need the will, if you would, and the resources to be able to make it happen.
Thank you. Anybody else have questions?
I don't have any questions specifically. Hi, my name is Jackie Montgomery. I'm the Director of Nursing at Bellevue, and I don't have any specific questions, but I just wanted to say thank you, both from a DEI perspective and just a healthcare perspective. It's really eye-opening to hear a little bit more of this, and also to know about a little bit more about the Damien Center and the offerings that you guys do provide. I think that it's a great community resource and something that not everyone knows enough about. So it's great to know that that's in our neighborhood and something that we can definitely refer patients for.
Thank you, Jacqueline, so much. And it truly is, Black and brown communities have just been devastated by HIV, and it continues today. We hear oftentimes in sections in Albany where it's called the monster. They've got the monster. And this is about health. This is about making sure that people are going to live healthy. And so what we are really doing is really trying to break down all of those barriers and create a really safe, inclusive space for people to feel comfortable enough to be able to tell us what's really going on. So sometimes people will come in and they'll have an issue, but really the issues are multi-pronged. And so when they trust us, they really open up, more so sometimes than they do with their doctors or with their case managers. So we're able to help them, and guide them, through these processes. I see in the chat that Richard Morin asked if we foresee the development of a vaccine in the next 10 years. I'll be honest with you, I had given up hope in the last 10 years that we were ever going to cure AIDS. It is a very tricky virus. They actually say it's a very stupid virus. It keeps replicating on itself, which makes it so hard. It keeps making mistakes on itself. So it keeps, reinventing itself, if you would. But there has been some really great news recently about some HIV vaccine trials that have been published. And so I'm actually returning to some optimism that we can certainly, get a vaccine for HIV. I think also, COVID and HIV, two totally separate, and even the vaccines, totally different, separate things. But I think those of us working in the HIV field, when we saw how fast and really relatively fast we had a COVID vaccine developed, when the whole world got together and said, we're going to make this happen, we kind of said, gosh, can't we do this now for HIV? Can they not get back and say, okay, you know what, 40 years, enough. Let's put the best minds together and let's get a vaccine together. So I really want to believe that it's possible. Again, we need the resources and the will to do it. So that's one of the things that we do at the Damien Center, is we keep speaking up and saying how important it is.
Thanks, Peter.
Sorry.
You got that next question there. Is PrEP education something foreseen for high-risk adolescent healthcare?
Absolutely. So PrEP is free in New York State. Again, a lot of things in New York State we're very fortunate to have, as opposed to some other states that don't put as much money into their healthcare infrastructure. And PrEP education is absolutely something that we are working on more so to get out to adolescents. The highest group of persons right now, the age group that are becoming HIV infected, are between 13 and 24. So that's our youth. And we have to recognize that at 13, when we have 13-year-olds testing positive for HIV, we've got to start arming them with some more than the condoms. I often say, and this is in no way, I know this is being recorded, I'm not saying throw away your condoms, but we also have to talk real sometimes and say people aren't using them often. And I think that is something that we have to recognize, that we need some other tools in order to give people to be able to protect themselves. We had some great success with needle exchange. And I think that was also recognizing the fact that, first of all, it works. It reduced new HIV infections due to injection drug use down to close to 4% of new infections, which is, I think I want to say last year, there were 86 infections in New York State due to the sharing of needle exchange. And that's directly attributed to needle exchange programs. Now, again, you'll hear from people, a clean needle feels better. So it is desirable to have clean needles, so these are things, if we can make it easier for people to be able to protect themselves. And again, PrEP is really revolutionary, when it comes to being able to prevent HIV infections. Again, when we talk about the education, we have to always put the disclaimer: it will not prevent pregnancy, it will not prevent STIs or, hepatitis C, but for at least STIs and hepatitis C, we have cures for those, so I'm a big believer in sexual health care and ensuring that people that are sexually active or that are using injected drugs, that they routinely get an HIV test and routinely are tested for STIs in a very comfortable, welcoming, and trauma-informed space on a regular basis. So it's not, I'll talk to some people sometimes and they'll be like, oh, I'm HIV negative. And I'm like, oh, good for you. I'm so glad. When was your last test? Oh, it was like 5 years ago. I'm like, okay. I'm like, okay, let's talk about why, in the past 5 years, you might need to redo that test, and again, depending on, your lifestyle or the choices and behaviors that you're making, there are ways to reduce the risk, absolutely. But getting a test and knowing that you're positive or knowing that you're HIV positive is so critical to being able to live a long life. If someone is diagnosed and goes on meds right away, they can now live a life just as good as a person who is not HIV infected. And that news is, just amazing today, I think. That wasn't even the case, 20 years ago when we had the new meds starting. So that's something that we try and tell people, no, I don't want you to become HIV positive, but you know what, if you are, you get on the meds. And I think that's also why you've really seen a real change in who HIV is truly affecting. In the beginning, there were a lot of gay white men, especially gay white men of privilege, who were becoming infected with HIV and dying of HIV. You're not seeing that, and I'm not seeing them at the Damien Center because they get on the meds. They find out they're HIV positive. They get on the meds. They may not even lose a day of work. They just continue on. It's really for the persons who are having trouble accessing the medicines that we really have to worry about right now. And again, we go back to all those contextual factors.
That's a good segue to the next question that came in from Jenny Glia. She raised the question of, if somebody shows up and they're already moved into full-blown AIDS, let's say their viral load is skyrocketing and their CD4s are super low, is there still a possibility of turning that around?
I mean, again, I'm going to preface, I'm not in the medical field, but from what I understand, absolutely, there still is that possibility, because as soon as the person starts taking the HIV meds, it stops that virus from chomping at the immune system. And if you can get that virus down, that gives the immune system a chance to rebound. Now, it may never rebound to what it was. Mine never did. My T cells right now, I think the last count was 480. So anything over 200, we consider awesome, right? Anything below 200 for T cells is of a concern, that you really have to watch. You can pick up some diseases, the opportunistic infections that normally your immune system would protect you against. The hard part with having full-blown AIDS and having I've seen viral loads in the millions where someone has 2 T cells. The problem is that it's been doing damage to the body for a very long time. It's been fighting. And that virus has really pounded that immune system down. So it's going to be much harder. Also, if the person comes in, and oftentimes it's because they have an opportunistic infection like PCP pneumonia or Kaposi sarcoma. So we're already dealing with another set of issues on top of having no immune system that we have to fight. So I would say certainly the longer it takes someone to get on medications, the less chances there are. But there's always that possibility for reversal. We have seen it.
Thank you. Any other questions out there for Perry? We certainly appreciate you taking the time and sharing your story and getting word out to us about the Damien Center and all the good services that are offered.
Well, sorry.
That's all right. We're gonna make sure that this gets up on our intranet so that others can see it. It's, in our environment, it's difficult for people to step away and see these, but if we can put it up so that they can see it at their convenience, hopefully people will view it.
I would like to thank all of you for the work that you are doing. Tony comes home and tells me the amazing stories at times of the work that you're doing at Ellis Medicine. And if I could just encourage all of you to, offer an HIV test to somebody and ensure that we're talking about this, because you really are, in addition to working on, the person's broken leg or, something else, is that opportunity to have that conversation with them and to tell them the HIV test, it's a quick swab. It's really a painless, test that can really, better to know than not to know. So the more we can get this word out there that this still is an issue, but we have help if we know, I would really appreciate that. So thank you for all the work that you do, and thank you for inviting me today. I really appreciate it.
Yeah, if you don't mind just taking one more moment, another question just popped up about non-compliance with medications, and do you find that to be an issue?
Absolutely, and I'll say from my own experience, there are times when I just don't feel like taking the meds every day. There are times when I forget. There's times when I get into bed and I'm all nice and cozy, and all of a sudden I'm like, oh, didn't take my meds. I'm like, okay, I'm gonna get up and take them. Yeah, you know, so medication adherence is probably the biggest issue that we have with persons who are not, because you really can't stop go the day's meds. You really have to take them every day as prescribed. And so we often find that persons, again, if they have mental health issues, if they are suffering from depression, they will not take their meds. If they have an active substance use disorder, they may not take their meds because they don't, they're not really aware of maybe, what's going on. It's not a priority. Are homeless. There's no place to store the meds when you're homeless. You're constantly moving. You've got your belongings in a bag, so it's really hard to be compliant. And then also sometimes life. You get busy. You're taking care. We see a lot of women having trouble with compliance because women are so busy taking care of the family, taking care of the kids, trying to work, and taking care of themselves sometimes comes last. And so. Taking that med every night sometimes is the last thing on your mind when you're trying to make sure the kids are fed and that we have enough food to eat and things like that. So probably one of our biggest challenges is to support a person with HIV, to take their meds every day.
Just a quick story around that issue. Perry and I were working with a young man probably 10 years ago who decided to stop taking his medications. I was serving as a chaplain with community hospice. I happened to get assigned to the case, and Perry, the young man, worked with Perry at the Damien Center. And we were both devastated that, nothing we could do could get him to start taking his meds again. And basically we just came to the, resolve that this was his choice. He had made the decision that he just wanted to live without taking the meds as long as he could, and we supported him through the end of his life. So sometimes it's just a choice that people make based on everything that's going on in their life.
And those oftentimes can be the hardest ones, because I was using every tool in my toolbox to try and convince him, and he was quite adamant. He had a deep faith. He said God is going to take care of this for me, and God's going to decide, and I don't want to preempt it with a lot of these drugs and things. I even got to the point where I'm like, okay, I'm going to mash these pills up in his apple juice every morning and give it to him, and talk myself out of it and say, okay, that's not legal. But to finally come to that acceptance that this is his choice. And so that is a lot of also what we do at the Damien Center. We respect people's choices, even if we don't agree with them. And we'll be there like we were for that gentleman, right up until the end, holding their hand and making sure that they're not alone. Too many people with AIDS have died alone. And I can say, oh my goodness, Tony, over the years, we have been to many deaths to make sure that people are not alone when they are going through the dying process, which is something that's truly magical, in my opinion, to be there with someone.
Thanks again, Perry. We're going to let you go. And it's been wonderful. I always learn something new from you, even though I'm with you most of the day, every day. All right. Well, be blessed and take care, everybody.
Thank you.
Bye-bye.